I'm here today to talk about the abutment selection in tissue modeling and implant dentistry. Basically, I'm going to be talking about shaping of the tissue. And we know this is a challenge for us, and we know that there are certain things that we have to accomplish. The first thing we have to accomplish is to have an emergence profile as the crown is emerging from the tooth. We're not only dealing with the white, we're dealing with the pink aesthetics as well. The second thing, we want to have the integration of that tooth within the context of the soft tissue of the adjacent teeth, extremely important. Then we have to have the laboratory get involved because we want to mimic that natural tooth just to be like the other teeth in your mouth. And the most important thing, when we put it all together, is that we want to have stability, because that's what our patients are coming into our office for, stability for a long-term period of time. Now, we always talk about this in terms of the anterior tooth, but it also extends to the posterior tooth. And if we take the component of color out of the equation, we're left with a soft tissue texture, form, contour, and basically what we want to see with the posterior tooth as well is that those three parameters are going to match that of the adjacent tooth. When we put the parameter of color back in there, we want to see it just like with the anterior tooth, that it is going to be matched up just perfectly. So those are the things in a nutshell that we're trying to accomplish, and basically how are we going to accomplish that? Well, I put this up here because questions are always asked, which abutment is going to give us the best result? And we'll come back to this picture later on, but I want you to take a look at just some single teeth restorations that we've done in our office, going from the left to the right. It would be tooth number 8, 7, 11, 9, and 10. And just picture this and just think in your own practice what kind of abutment you would be using in your patient's mouth to get these type of results, or what is your favorite type of abutment to use. Because basically what we're trying to do is we're trying to hit the bullseye every time. And we've talked about this for the past couple of days, and we'll be talking about this for meetings forever. And the reality is that sometimes we do fall a little bit short about this, but what we have to see is how we're going to be able to accomplish that. Now, when a person comes into my office, I'm a prosthodontist, I don't do any surgery, although this year I am on track to extract 5 teeth, so it is going to be a pretty good year for us in our office as far as the surgery goes. But I am under the assumption that all the hard tissue grafting or all the soft tissue grafting has been done ahead of time, that basically all I have to do is go ahead and just deal with the tissue that I'm dealt with and see what kind of results we can get with that. So I'm not talking about anything as far as any post-tissue grafting, post-surgical placement grafting, or whatever. And this is very important because there are a couple of articles that have been written about this. One just recently by Dr. Fu Li and Hamli Wang, published in AJOMI, where they talked about the influence of the tissue biotype on the implant aesthetics. And basically they wanted to see in this article how they can get a certain thickness of tissue biotype to get the best aesthetic result. And the other thing that they said in this article is they said, look, we know that there can be surgical modalities to accomplish this, but this article is going to only be from a restorative aspect. Redamangi talked about this too, the thickness of the buccal mucosa and how important it is for the long-term success in implant dentistry. And then he goes on one more sentence and he says, especially in the anterior area. So this is what we're trying to accomplish. And basically what Hamli Wang and his group in Michigan did, and this was just an article not devoted to any implant system, it was just about concepts, was to come out with a concept called the PDP management triad. That when you put these components together, you're going to be able to achieve a thicker type of tissue. So they talked about the prosthetic design, which means that you're going to have an abutment or a crown, which are going to be concave in profile. They'd like to see an implant design that has a smaller diameter of implant, which is going to have a platform switch built in, and they'd also like to see an implant that could be placed subcrestally in a more apical palatal position. When you go ahead and you put all those together, and we know that we could accomplish a lot of that on a predictable basis today, basically what we expect to see in our practice would be a situation like this, where we have an abutment and a certain thickness of soft tissue just facial to that abutment. And when you put all these components together, what we're going to do is we're going to get that increased thickness of the peri-implant mucosa, which is very important. And it's important in the anterior area because, as Stephen Chu and Dennis were talking about earlier, we want to see that their color is going to be hidden. So when we have a thicker amount of tissue, it doesn't matter if we have a large titanium abutment, it doesn't matter if we have a smaller titanium abutment, it doesn't matter if we have a zirconia abutment. When we highlight that area right above the margin of that, we hope that we're not going to be seeing any discoloration of tissue. And they gave some great stats this morning about measurements that are very important to us. Well, let's take a look at some of the other studies, because one of the studies that people like to quote all the time is Ronald Young's study, where we need 3 millimeters of soft tissue thickness in order to hide that the eye cannot discern whatever is behind that tissue. And we're always taking a look at it from a view where we're looking down on the implant and we're trying to see where that 3 millimeters is. But the most important measurement that we have to see is not looking down from an axial view, seeing where that thickness is, but from an incisal-gingival view, where are we going to get that 3 millimeters? And this is where the research is a little bit short, and they are doing a lot of work in this in Columbia, along with Team Atlanta. But one of the articles that I like talking about is von Brankel's article that was published a couple of years ago, because they were one of the few studies that actually measured in increments of 0.2 millimeters from the cervical margin apically to see what sort of soft tissue thickness there would be on an average basis. And a couple of numbers that hit me would be this one. If you go down 1 millimeter, we are going to have a soft tissue thickness of approximately 2 millimeters. Well, what's so unique about 1 millimeter? Well, 1 millimeter is oftentimes where we expect our lab technicians, or we ask our lab technicians, to go ahead and make the final margin equidistally around the implant so that it's easier for us to go ahead and clean off the cement. Well, that may be fine for some studies, but if we have a thinner type of biotype, or if you go by Ronald Young's study, we need 3 millimeters, and we're not going to get that 3 millimeters until approximately 2.2 millimeters or so apical to the cervical margin. That may be a problem as far as cement removal. So the question is this: how are we going to get this thickness with the components that we have? We follow a certain principle in our office that we name the ACT principle. It's a very simple principle. A plus C equals T, where A is the abutment, C is a crown, and T is a tissue. Now, there are no numbers that get plugged into this formula. This is, again, just a very simple concept, because there is only one answer for T. T has got to be perfect. The tissue shape has got to be perfect. It can't be under-contoured, it can't be over-contoured. So when we have that perfect tissue, it is going to be made up of a certain percentage of the abutment and crown. Now, is there a perfect percentage, or a most probable percentage that is going to give us the best result? Well, that's what we'll spend the rest of this time talking about. The other interesting thing is that all these components, the abutment, the crown, and the tissue, have the parameters of shape, color, and contour built into them. And each one is going to interrelate with the other, and it's going to have a synergistic effect upon the potential positive results that we're going to see. So let's just take a look at it from the most simplest point of view. We know, for instance, in the anterior area, we want to have a cross-sectional emergence profile of a triangular shape. So according to the ACT principle, if you have a smaller abutment, you'll have more room for a crown. If you have a larger abutment that you're going to be using, you'll have less room for a crown. But we have to fill up that space. It doesn't matter what the proportion is. But it is going to be determined about possibly depending upon where the implant is placed. The same in the posterior region. Smaller abutment, you'll have more room for a crown, maybe better for the technician. Larger abutment, less room for a crown, and maybe a little bit more difficult for the technician. Either way, what we're trying to do is to get this optimal emergence profile that not only from the buccal region, but from the sagittal region as all, so that we achieve optimization for our patients. That's basically what we're trying to do with those two components involved, the abutment and the crown. And as I said, it just doesn't apply to the anterior teeth. We know that posterior teeth have a cross-section as well. So if we take a look at this cross-section over here as outlined by the green, if we just go ahead and x-ray through that crown, you see that we have a smaller abutment there. That's fine. We're just going to have more room for a crown. It may be a little bit more difficult to clean up, but it's going to work. It doesn't matter. If we go ahead and we morph that abutment into one that's a little bit more anatomic, it's just a larger abutment, less room for a crown, but the emergence profile is still the same. And if we even go one step further and have a CAD-CAM abutment, now you see that we have more abutment, less crown, but the emergence profile is still going to be the same. And it applies from the occlusal aspect. Take a look at the right side of the screen where the T is, where the tissue is. It doesn't matter if that's a smaller abutment, it doesn't matter if it's a larger abutment, or even a larger abutment than that. The tissue shape has got to be the same, so we have to work in the confines of the tissue. And that's why, quite frankly, in our office, I don't have a feeling one way or another, of what's going to be used on a particular case. I'm going to use an abutment which is going to give us the best results for that particular patient. So we have two situations here, two different patients, two different situations, actually. One, the implants were placed perfectly and we were able to use preformed abutment. The other ones, they were a little bit awry. We had to use custom abutments. But it doesn't matter because when you take a look at the final crowns and the tissue, which is going to be really the truth serum for what happens, you see that we could achieve both ideal tissue independent of the type of abutment or crown that we're going to use. So the question is this: what is the function of the abutment? Well, in its simplest terms, we know that the abutment is a connecting element. We know it has a biomechanical function, it has a biological function, and what we're trying to do is combine the two and get the best from both. And there was a great quote by Dr. Ingeborg de Kock out of University of North Carolina stating that the abutment should develop or enhance natural architecture and protect biological function. And I think that's a great quote. So now we go one step further and say, well, we have that ACT principle, the A plus C equals T. How can the abutment help us in getting thicker tissue? Well, there's a law of nature, and a law of nature says that two things cannot occupy the same space at the same time. So you take a look at this poor guy over here where his nose is now going to be a little bit to the side, so the ball's going to be taking its place. Well, let's take that concept and apply it to implant dentistry. And by the way, these next graphics are out of a text by Canulo and Cocchetto, published last year by Quintessence on a peri-implant tissue remodeling. And basically what they said is that, you know, we have this peri-implant biologic space that we're trying to fill in. And if we have an abutment that is going to be divergent, then that is going to have a direct effect, a direct correlation to the thickness of the soft tissue that is going to be there. We then throw in the crown contour, and depending upon if it's going to be over-contoured or not, that will have an effect upon the zenith position of where it is. Now, that is okay. This type of design of abutments is great. This is what we've been using for years. This is what we try to achieve in ideal crown and bridge preparations. But it's good only if we have enough space to utilize this. Remember, we're dealing with a limited amount of space, so if we're taking up too much space with one component, we're going to have less than the other component. So the whole concept is that this is great when we have enough room, but oftentimes we don't. So what I'm asking you now is to take a look at from the abutments from a different perspective. Going back to their text, they said, you know what, instead of having a divergent abutment, let's change the shape of the abutment and make it convergent. We're still filling in that same peri-implant biologic space, but now there's going to be more room for the soft tissue because there's less room taken up by the abutment. Two things can't occupy the same space at the same time. They even go one step further and said, you know, that convergent shape of the abutment is great, but now let's put it on a platform switch abutment, a platform switch implant, or take advantage of the platform switching concept. Then when we take a look at those arrows that we had from the divergency, or where the thickness of the gingiva was at the very beginning, we now have gained this amount of tissue simply by doing nothing other than changing the shape of the abutment. And that was automatically. And what they stated so eloquently in their text is that they said this: change the spatial relationship between the shape of the abutment, the crown, and the gingival tissue simply to favor that of the gingival tissue. So that's what we're trying to do. So what does this have to do with implant dentistry? Not too much, but it is a pretty cool picture, I have to tell you. No, there is something. A friend of mine sitting out in the audience, one of my colleagues with whom I work quite a bit, a periodontist in St. Louis, Bill Cohen, was sitting around, and we practiced in the same building, and said, have you ever seen a fighter jet go through the speed of sound and you get this vapor cloud around there, and it just engulfs this jet just so perfectly, the jet's right in the middle of this vapor cloud. And he said, you know, that's how it should be with implant dentistry too. We should have that implant placed just perfectly, that we have this soft tissue, this ideal soft tissue that is going to just envelop this implant. And by the way, the phenomenon that he was talking about is called the Prandtl-Glauert phenomenon. It doesn't happen all the time, but when you do see it, it does look pretty neat. So when he takes a look at this, and then we talk about putting the abutment in there, and that's also going to be surrounded perfectly with the soft tissue, he entitled this, and this is his term, the biologic envelope. So let's see how the abutment selection is going to be affected by this biologic envelope. We have a convergent abutment over here, and we also have a beautiful anatomic abutment over here. Now we're dealing with a space. This happens to be tooth number 23. And we're dealing with a space, and we don't have a lot of room. So in this particular situation, we chose a convergent abutment. Now the green is the biologic envelope that Bill was talking about. You can see when I overlap the anatomic abutment, which is divergent, with the other abutment, which is convergent, take a look at how much more room that divergency is taking up. Well, in a situation like this, if we took that divergent abutment and put it on in that space over there, we would be outside the biologic envelope by that amount. And we don't want that because we don't have that much room. We don't want to be outside the biologic envelope. It's a very simple concept. And you can see from the occlusal view over here, that's how little room that we have. So the rule is you don't want to be outside the biologic envelope, and in a situation like this where we did have limited rule, this convergent abutment was the one that was going to give us the best result for a long period of time. So it's just a very simple solution on a very simple case, but yet the whole key is to having the stability. Well, that's one thing that the abutment could help us do. The other thing is we need to understand a little bit about the biology of wound healing. Stephen Present wrote an article in Inside Dentistry on guided wound healing a couple of years ago. And he was talking about this, that we're on a time clock from the time that the implant is placed until we put on a final restoration. And by the way, these are his slides. He was kind enough to send me these slides based upon an email that I sent to him. I never met him, so I didn't change these at all. But basically, he talked about the phases of tissue repair, the bleeding, the inflammation, proliferation, and remodeling. Anything that's taking place from minutes going out to months. He then overlapped this with the timing of the soft tissue conditioning and the aesthetic sites of different things that we're going to be doing in order to shape the tissue to get to the final result. But the key thing here is this 1 week area for provisionalization, because the next concept that we're going to be using to choosing our abutments is the concept of workflow. And Henry Salama uses this term quite a bit, and I want to thank him for this. Workflow is the reason that we're choosing the abutments based upon a certain protocol in our office. Let's take a look at what I'm talking about. We have a solution over here, we have a situation over here with a hopeless tooth, mucogingival defect, and whether we want to debate or not whether we could have done this immediately or not, we did. We did this immediately. So we extracted the tooth, and then Dr. Cohen went ahead and placed a soft tissue connective graft. He then placed the abutment on at the same time, placed a provisional restoration on at the same time, and placed it subgingivally. So basically, in this one case, we're following everything that Homley Wang was talking about with his PDP. Smaller abutment, narrow and concave, place it apically, and everything else with a provisional crown as well. And according to Stephen Presence, we have the immediate provisionalization. We have it up to 1 week that we can do it, but we generally go ahead and do it immediately. That is our workflow. Well, here's a whole advantage. We take a look at this 4 months post-surgery, and you just see beautiful soft tissue. In fact, up to this point, I haven't done anything at all. Bill has done everything. So you can see the advantage of placing that abutment on at the time and having a convergent abutment that we're getting a thicker amount of soft tissue. So finally, I come into the act, I do a snap impression, with a pickup impression, the laboratory makes a crown for me, and you can see the beautiful result that we have. But we take a look at what was going on from the beginning of this particular case to the final result of this case, but here's a whole key. The key is that the final preformed abutment was put on at the time of surgery. We use a lot of CAD/CAM abutments in our office. I don't want you to think that I don't. But when we need an abutment immediately, then we have to go with something that is going to be preformed, that is going to work for us. And we'll take a look at a little situation that's a little bit more dire. This lady is 88 years old. She comes into our office. And obviously, there are a lot of problems. And as Dr. Lerner would show yesterday, this is a case where it's actually a full mouth reconstruction, but quite frankly, an 88-year-old lady is not going to be doing this, especially in St. Louis. So what we did is we went ahead and extracted the teeth. What Bill did is he went ahead and extracted the teeth, placed the implants on it at the same time. And by the way, how far did we know to go subgingival? Well, because we had these abutments in the office, we placed the abutments on the implants at the time as he was putting them in, and based upon the clearance that we had between the top of the abutment, or the coronal part of the abutment, and the opposing tooth, we then knew how far subgingivally to go, or subcrestally to go, and then could take off enough bone to accommodate that, so we wouldn't be too far subcrestally. Well, we take a look at that, and then we have the provisional restoration. So now we have two of the components to the ACT principle. We have the abutment, and we have a provisional restoration, the crowns that are going to be shaping the tissue. Well, here's the impressive thing. When you see it 3 months post-surgery, you can see how beautiful that tissue looks. And you can see how thick that tissue looks. We're getting that thick tissue biotype just by utilizing certain shapes of the abutment and the crown. In fact, when we take a look at it, with the abutment and the crown with which we started, and we then take a look at the final restoration, starting off from something like this, it would be seeming like it would be an impossible thing to do, very dire situation, but it was accomplished with great predictability. And we were also taking advantage of the concept of one abutment, one time, which again works in our office. And this has been spoken about by Abramson back in 97, 2003. Henry Salama has coined the phrase for so many years. George Romanos talks about this, his latest article by DeGidi and Narti and Piatelli. So when we start off with a situation and wind up with a situation like this, that preformed abutment was a big thing. Did the abutment shape the tissue? No, it was just one of the components that gave us a result that we have. And that's the thing that we have to understand. But we have to talk about the crown because I've just been speaking about the abutments. So let's see what the contour of the crown has to deal with as opposed as in assessing the emergence profile and getting a very good emergence profile with the contour of the crown, because that's the other part of the equation that we want to talk about. We know that in natural teeth, there is a correlation between the bone, the soft tissue, and the crown contour. In its simplest terms, if we have a situation like this with delayed passive eruption, we know by doing the crown lengthening and removing bone is going to go ahead and reshape the soft tissue. It is going to reshape the shape of the teeth. We also know it works the opposite way, that if you have an incorrect crown contour or incorrect contour of the tooth, it is going to be manifested clinically in a form of inflammation, recession, and it doesn't matter if it's going to the anterior or posterior tooth. So there's that definite correlation. This correlation is also true with implant dentistry. And I think a great quote that Lyndon Cooper had is that the majority of aesthetic problems are often due to discrepancies in implant crown dimensions and orientation. So I want to discuss a basic prosthodontic principle that we don't talk enough about, and that is of contour, the contour of the crown. Now, there was an article, a great article that George Priest wrote a few years ago showing the relationship between a crown contour and a soft tissue profile. In fact, Sue and Gonzalez just published something in the International Journal of Perio a couple of years ago where they talk about the critical crown contour having to deal with the zenith position of the gingiva of being 1 millimeter before that crown emerges from the tissue, and that's a critical crown contour. So let's see how this plays out when it comes to our implant dentistry. We know with our provisional restoration, we want to attain the tissue to the optimal level. And here's the optimal level, the adjacent tooth. Here's the optimal level of the implant, except it's not. And here's the one next to it. So what is going on? Well, just using the polycarbonate crown that fits so nicely in there, you can see that I've apically positioned that tissue. And this is one time we don't want to apically position any tissue. So just by simply changing the crown contour of that provisional restoration, we will get immediate and dramatic results in the shape and the health of the soft tissue, as talked about by Lay and Gallucci in one of their articles. So the contour provisionalization is extremely important, and it's going to give us the stability that we need at 2 months, at 2 years, and then finally at 6 years, and we're not seeing any change whatsoever. And if you notice, that abutment that was underneath there was just a very convergent abutment. It was a stock abutment with nothing. So we have to put it all together, so I want to just close with a couple of cases to show you how the abutment choice affects something and how the crown contour is going to affect something. The abutment choice. Here we have a beautiful zirconia abutment that was made, CAD-CAM, but take a look. We have a very divergent profile at the gingival aspect. Beautiful anatomic. That divergency of zirconia allowed me to make a provisional restoration that was only this thick. As a matter of fact, it was very thin. By then putting that on the patient's mouth and still keeping the facial contour within the context of the other teeth, you can see how high the gingival level is on that lateral incisor. Very poor aesthetics. So what do? Just following the ACT principle, we change the shape of the abutment. So now we go from an abutment that had a divergency to one that has a convergency. We're now favoring the soft tissue. That changing the shape of the soft tissue is enabling us to take that same provisional restoration, relining it. Now you see how much more room we have with the crown contour. And then ultimately, that crown contour is going to be able to shape the tissue a little bit better. And then we have our final result over here. So when you take a look at what we started with, how high the zenith position was of that lateral incisor up here, and then when we put the final contour on, Same, no tissue grafting, no connective tissue grafting at all, just changing the shape of the abutment, which changes the shape of the crown to favor that of the gingival tissue. And it works the opposite way too. Here's a patient of mine that came back with too much tissue. And the surgeon said to me, put on your provisional restoration, this was a delayed approach, and when the tissue heals, send the patient back to me and I will excise that tissue. I'll use a laser, a scalpel, or whatever. Well, I didn't want to do that because what if he takes off too much? So just following the crown contour principle, in that article by Sue and Gonzalez that was published, we took that critical crown contour where the provisional restoration was removed from the patient's mouth. I took that 1 millimeter as where the tissue is going to be emerging, below where the crown is going to be emerging from the tissue. This time I want to get the tissue in a more apical level, so we just made that area a little bit more convex. We put it back in the patient's mouth, had her come back a month later, and you can see simply by changing the crown contour the dramatic result that we see in the soft tissue. In fact, when you take a look at how I overlaid where the tissue was originally and where it wound up, you can see the dramatic difference simply by changing the crown contour. We happen to use a zirconia abutment underneath that, but the question is this: what corrected the zenith position of the facial tissue? Was it the abutment? No, the abutment had nothing to do with it whatsoever. It was the crown contour. It was just a combination of the two things. So we're lucky today. We've heard so much about digital dentistry. We've seen some excellent, excellent presentations, and this is where things are heading. But the one thing about shaping the tissue is that when we all went into dentistry, we know that there is an art and a science to dentistry. And one thing that I feel very strongly about is that shaping the tissue is not a precise science. It is an art, and there are a lot of options how we can do that, but it is an art. As far as utopia, somewhere else down the road, but it's not here just yet. I subscribe to what Dermot Gallucci said: of greater importance is the soft tissue handling at the time of implant placement. So what better way to go ahead and shape the tissue at the time of implant placement that even again when we have such a dire situation with a tooth that is so externally resorbed, but we can go ahead and clean it out and bond it onto the abutment that we're going to be using, and then go ahead and utilizing that as our provisional restoration. This is optimal tissue handling at the time of implant placement. And then when we see it about a year and a half or so later, you see a beautiful soft tissue result around there. And when we take a look at the abutment that's underneath, it's probably like the last type of abutment that you thought would be used in a situation. But there again, it's a combination of everything. So you can use large abutments and fill up the space with the abutment. You can use small abutments and fill up a little bit less space of the abutment and more with the crown. It doesn't matter. You're going to get good results with both. The same with the posterior. Beautiful anatomic abutments, or you can use some preformed abutments that are a little bit less. You're still going to get the same result. In my eyes, it does not matter whatsoever. No matter how complicated the situation is, I just try to bring it back to the fundamentals. And the fundamentals that we're dealing with shaping the tissue are we're dealing with the abutment and the crown, with the form, the shape, the contour, and the color of both. So when we go to that original image that I showed you, and I said, what kind of abutment would you think is going to give us the best results for this? You may be surprised. There's a straight titanium abutment. There's a little bit more of an anatomic abutment. There's a zirconia abutment and another angle type of titanium abutment. And finally, a gold hue Atlantis abutment there. It doesn't matter. We got the great soft tissue results regardless of the abutment that we're going to use. It's a very simple concept, but it's one that we use in our office all the time. So, to summarize, we are what we repeatedly do. Excellence then is not an act, but it's a habit. So, from St. Louis, Missouri, I appreciate, and by the way, I want to thank, I'm going to use my time now to thank all you guys for having me. You did such a tremendous job with your first symposium. Thank you.